in these layers now that we have to peel back now or not peel back, really. We don't have to peel back much of anything. We just have a bigger beast. I will call this thing Hydra. we shall name the healthcare system Hydra.
You mean like whack-a-mole?
We get one and then another one pops up. Boop. That's right. That's kind of like how it is. Like, one thing we get, we expand Medicare, and then here comes like Part C with all the health plans, and then we, don't get me started. But like Knox-Keene, the Managed Medicare Act, all those things didn't exist when they were implementing Medicare that they had to worry about, rolling back and all that, and or working within. And I was just like, so we do have a bigger mountain to climb than we did if we were just like back in 1960s trying to implement Medicare.
See, now I'm thinking, when I'm thinking of whack-a-mole or the heads of the Hydra, I'm thinking literal, like human beings, like who's going to come at us this time? Last time it was Speaker Anthony Rendon, but which head of the Hydra, which mole do we have to whack this time? But really the way you beat that game is by raising the whole discussion, raising the whole level, so that the moles under the surface are all brought up to the surface to be exposed, right? So that's what we got to do. Everyone wants to go after Gavin Newsom or Speaker Rendon or Jim Wood, but we have to go after these people running for dog catcher and people running for city council, for school districts, because if they get on board, all of these Democratic central committees and clubs, if we get enough of them on board, they're clamoring for this thing, then those politicians up the top can no longer ignore the people in favor of money, because there's too many people. We then have exposed all these moles, all of them, all at once, not just the one that pops its head up, kind of.
Yeah,
that's the first time I used that analogy.
Let me interrupt for 1 second, just for we'll get going in like a minute or two, but I just want to anybody who's watching on Facebook Live, just that you're in the right place. This is CalCare weekly office hours, a joint production of PNHP, SoCal, and Healthcare for All Los Angeles, and we're going to get started in a minute or two. Let some people join us. Go ahead.
There he is, Dr. Richard Wynn. You are awesome at the convention. Ooh, 2 thumbs up at the convention. You're awesome.
Oh, no, you were amazing. Thank you so much.
Just for those of you guys, the California Democratic Party had a convention over this weekend. And a lot of us healthcare advocates were there, to make sure AB 1400 stayed on the legislative consent calendar and nobody tried to pull it, and to fight for resolutions that we had submitted. One, like, for example, asking for the governor to apply for the federal waivers that are needed to bring forth AB 1400. And, support other, resolutions that also support, healthcare, and amongst other issues. Like, this wasn't just a healthcare convention. It was definitely a lot of other issues that were on the table regarding affordable housing, et cetera, et cetera. But, this is for healthcare. So we were all there. It was very long and exhausting. If you, I'm sure as all of you guys are very virtually Zoom fatigued, but let me tell you, this weekend really pushed me to my limit. I actually despise it now. I do not, once we're really clear of this pandemic, if you mention a virtual meeting to me, I'm not going. I'm sorry, I'm not going. I don't mind. I will come to Orange County. I will come to LA. I will just come where you are. I'd rather see you in person, at least for a little while, because I'm just over it. Even though, unfortunately, I just have to give a shout out really quick to Bronwyn Major. She's been our graphics person. So if you see the graphics behind, a few of us, Bronwyn and then Betty with the ideas to create these graphics, Unfortunately, we didn't get to utilize them as heavy as we wanted to because the party, one good thing about what the party being virtual is that the party can silence us when they want to. If we were in person, we probably would have had these on signs, like holding them up, like, yeah, you know, actually, that's still not a bad idea. We might need to get these on signs. And they wouldn't be able to control us that way. But because we're on Zoom, they can turn off our video capabilities. They can disable chats. They can do whatever they want. And so it was kind of sad that, you know, these awesome graphics did not get to be displayed as heavily as they should. Or could have, but you know, that doesn't mean that I won't put this on a sign and show up at the next convention. I mean, the way the vaccination rates are looking, maybe we might have a limited capacity convention in the fall. I don't know, maybe. But you know, I think I just want to give a shout out to Bronwyn because, like I said, she's our graphics person. She does this out of a labor of love, and we love her for it.
Yes, thank you, Bronwyn. So why don't we're let's get rolling. And so again, welcome to people who are out in following us in live streaming and Facebook. This is AB 1400 CalCare Office Hours. God, we're about at edition 6 or something like that. But we just keep at it because there's the people. We just need to continue to do the work of getting word out, answering questions about what this is all about. So the briefest of intro, and then I'm going to turn it over to, so just, you know, I'm Ron Birnbaum, a doctor in LA, an activist on some of these issues. There's some other wonderful people here. The other co-host is Jeanna Harris. And we're going to hear from Jeanna in a second. But what I wanted to just say, just the broadest sort of understand, what is office hours? So in February, the legislature introduced a bill, AB 1400, which would do a single payer program in California. This bill is going to be considered over a 2-year period in a legislative cycle, of which the next big major events are going to be in the early 2022, which isn't to say, but there's a lot of work to be done in understanding, in growing movement and understanding of the bill between now and then. And so that's one of the things we've set up CalCare Office Hours, which is a joint operation of Physicians for a National Health Program, Southern California, and Health Care for All Los Angeles, both advocacy organizations that are squarely behind this, which is to make a forum where people can come together and mutually educate each other and learn and ask questions. And so that's what we are doing today. And I'm going to turn it over to my Jeanna Harris, who's a co-host, outstanding co-host, by the way, and she's going to say just a little bit about the bill itself. Like, what is that bill? So let me turn it over to Jeanna.
All right. So, what is AB 1400? It is the bill of all bills. AB 1400 literally is the bill of all bills. If you look at like all the bills being put forth and for healthcare in California right now, it's a bunch of like kind of small piecemeal bills that are like only a few pages and 9-10 pages long, which is cute. This bill is like 60 pages. So that's why I say it's the bill of all bills. But I will go over the office hours. I want to go over the 7 basic principles that make this bill of all bills very simple. So I want to go over this, and like I said, this California Guaranteed Healthcare for All, CalCare, is what we're putting forth to fix our broken healthcare system. As someone who's experienced all ends of the healthcare system, from Medi-Cal to not having insurance to being fully insured with some, I don't want to call it top tiered, but I guess a PPO plan I pay for. I still pay a lot for it. I can tell you that this is also a health equity bill, not just providing equality to Californians, but equity. So right now, if you are, have a low income, are pregnant, or have disabilities, you may qualify for Medi-Cal, or what is our state version of Medicaid. That is such a apartheid healthcare system, because the care that you get being a Medi-Cal recipient is just subpar. You only get to go to certain places. Most providers don't want to see you because of the rates being so low, and you receive subpar care. Why do we have to deal with this? Why is it a crime to live in poverty? Why is it a crime to, not have the income of those that, are billionaires living in our same state? So anyway, I'm sorry, I digress. I just went down that tangent. Okay, so here's the 7 basic principles of this California CalCare Health Equity Bill of all bills. Universal coverage. We want everybody in and nobody out, regardless of your race, your gender, your country of origin, disability, immigration status, your marital status, your age, income. And some insurance companies are, religious-based companies, and we've heard this in the past, certain insurance companies not wanting to cover birth control, for example, and they get away with it because they can. But this will not be that. You can get your birth control, have your woman's reproductive rights in an equitable healthcare system. And then a single public program, single payer, publicly funded through progressive taxation, meaning the billionaires pay more than someone who's only making $30,000. Why should that person making $30,000 pay higher taxes than someone that's, making $30 billion a year? To cover the necessary care in California, we're going to eliminate unnecessary bloat, administrative fees. These insurance companies in the healthcare system pay so much in administrative fees just to sit there and they say cost containment, but it's really not cost containment when you're paying people thousands, if not hundreds of thousands, to be your cost containers. So are you really containing cost at that point? That's bloat. So we're going to save thousands on that healthcare cost. Full comprehensive benefits, including medical, dental, hearing, vision, mental health, very important, prescription drugs, long-term care, very important, and more. Most insurance companies, especially Medicare right now, does not cover long-term care, does not cover dental, does not cover hearing, vision, unless you get a supplemental plan or you go into a Medicare Advantage plan. And under those plans, you may get more benefit or what you think is more benefit, but you're sacrificing yourself in terms of how that benefit's paid out, the delays in utilization management. So that's not a perfect system either. And then also the decisions about the care should be between you and your doctor. If you meet the criteria that these doctors are trained to know for a procedure, then the insurance company should not tell you no, just because maybe, well, did you try this first? Did you try that first? Because that's that cost containment, but actually they're spending more money because they're sending you on a loop-de-loop just to come back to the conclusion that you've actually needed that procedure. I hope you just are alive to get through that. Anyway, freedom to choose your care provider. This is very important too. Most people think that if we go into a single payer system, what about my doctor? I like my doctor, and people think that that means you like your insurance because your insurance is how you see your doctor. Truthfully, yes and no. So your doctor is still going to be there. Your doctor doesn't go away. If they choose to participate in CalCare, they're still going to be there. You can still see your doctor. So now you won't have to worry about, being restricted to your health plan's network. And then subsequently, if you don't like your doctor, you're not married to that doctor. You guys can get a divorce. You can go away. You can just go find a new doctor without having to worry. Is it in network? Is it out of network? Is it top tier? Is it secondary tier? Will I have to pay? What copay will I have to pay? And speaking of copays, now we're free at the point of service. No more copays, premiums, deductibles. You go to your doctor, you show them CalCare, that I have a CalCare card, and you get seen. And you walk back out a healthy, happy person. Done. Just transition. So they're going to fund and program to, provide funding and programs to protect and support any displaced workers in the insurance industry. Maybe myself being one of them, but that's okay. Because you know what? I know that if we implement this is a step forward overall for California and for the country. I can, as a nurse, be able to go get another job. Maybe it might not have the same name, but what I do is still going to be needed. So I'm okay knowing that my company may say, okay, we're laying off people, and I probably will actually jump off this ship before it gets there, but I'm going to head over and work for CalCare or some type of administrative office or some type of, I can go back to the floor, so I'm okay with this just transition. Patient care based on patient need. Most importantly, like I said, going back to that fact that when you have, let's say you need a cancer treatment, and before you get that cancer treatment, they want to know, did you do this? Did you do that? Blah, blah, blah. Did you check those utilization guidelines? But your oncologist is saying you need this treatment. Why does the insurance company send you through that rigmarole of utilization to try and save the cost? Because they're not doing that to protect you from having unnecessary treatment. They're doing that to save money. They're hoping that that cheaper treatment works and that you don't have to get the more expensive one that your oncologist recommended. And that is why this supports the ending of financial incentives, to avoid providing necessary care, which is sending you through a rigmarole of spaghetti just to get you to, just to get back to the same point. Oh, though they really did need that medication. Once again, I hope you live through it, because several people don't. People die going through the rigmarole. And that is the 7 basic principles. I'm done. No more.
No, that's great. And so like, God, just ripping off truth after truth. Thank you. So one of we in general for Calculator office hours, we mostly just want to open things up to questions. But there's always a but. We often have like some little thematic theme or something or other we wanted to bring out from the week, and so that's something I want to go over, something like that right now before we're just wide open, and that is the chburp. We should have some kind of like noise, like a belchy noise.
Yeah, we should have a belching noise that goes with it. Burp.
Somebody here could probably do a good thing.
Burp.
Burp.
So what is chburp, and why would we even want to talk about it here? So let me begin by doing a little bit of sharing, and then I think it'll become more clear. So this is CHBURP. So CHBURP stands for the California Health Benefits Review Program. Doesn't sound super fun, but what is that? So basically, the Assembly, or the legislature, when it does health bills, if there's something of substance to them, then they've created, this was back in like the aughts, they created a think tank program basically where they could send the bill to an office that's in Berkeley, and that office kind of has relationships with a bunch of policy people all over the place, some in California, some not in California. And it says, hey, look at the bill and kind of like assess it for the Assembly and the Senate, for the California legislature. And so that did happen with this bill, and there was a report that was generated from that came out on the 22nd. And like, it would be nuts to go through everything that's in that report, but I want to share a few, I would say major one impression, general impression, and then a few of the specific things that were mentioned in that report, so we can think about them, because in a sense they maybe represent, I guess you could say, questions about what's in the bill. So, which is the business of CalCare office hours. And some of those questions, maybe there's answers for clearly, and we want people to kind of know the answers to those things. So first of all, the one general impression I wanted to share is that I do think that the people who worked on the CHBURP, that it wasn't like a hit job or something, that it wasn't they didn't start out. And the reason I could say that is I think that they looked at some pretty important pieces of literature and presented them that are broadly supportive. The Perry analysis of the last single payer bill, SB 562, major studies that look that show cost savings to single payer systems as a consistent theme, and they highlighted those. And I think that, I think that's right. And so, and at some point, maybe we'll emphasizing the positive from the CHBURP, but I want to focus on a few things where they sort of raise questions and answer some, and sort of point out where maybe their questions are not, how about put it this way? It's possible that those questions could be looked at by somebody who starts at the outset not wanting to support this bill and gets weaponized inappropriately against the bill. So that's where I want to arm people with that knowledge. So so first, I will mention that I looked carefully through the CHBRP, but so did other people. And there's a group that's also worth mentioning because they're players in the current system. Hang on, hang on. This is what I want to share. Let's see. Back to us. Okay. Back to sharing. Full screen. Okay. So for those so some people out there who maybe have heard of this organization called Healthy California Now, and maybe some people who haven't. So let me just share a little bit about who they are. So Healthy California Now is a broad coalition of single payer supporting groups, and that have been around for a while, for from some number of years. I think it's less than 10 years, but I could be wrong. Somebody could correct me on that in the chat. And some of the folks who are very closely affiliated with Healthy California Now did some evaluation of the CHBRP. And actually, I think they pointed out a couple interesting things that's worth pointing out. So one is that the CHBRP folks try to calculate how much money we spend on healthcare in California. And they probably undercalculated it by a lot. In other words, they came up with a number that was about 330 billion, and we're probably a little over 400 billion right now. And there's probably some reasons methodologically that they came up with that, but I think it's pretty clear that that's wrong. And so I think the take home from that is just because the CHBRP says something, it isn't necessarily true. And other things they calculate out, they just may not be right. And so, for example, one thing that they go on to calculate or try to provide the legislature is a sense of the reserve requirements at the outset that a single payer system in California might need. And a little out of the blue, they say, well, we think that you should have 50% of the money in reserve at the outset. And I think it's right to say, and the Healthy California Now evaluators said that it's probably too much, or it's probably more than is needed. So, well, just to dive a little bit into why. So 50% would be if you believe that, right now we're spending for something like 400 billion on healthcare, it's $200 billion, that's a lot of money. Or even by their estimates of 330, you're talking about something in the range of maybe 160 or whatever billion dollars. And they may be ignoring important things that, for example, already 70% or so of healthcare dollars spent in California come from the public sector, and including maybe 40% of the total is already from the federal government, which is a fairly reliable spender of money on healthcare. Year after year, it spends the money on healthcare. And so that money isn't necessarily going to fail to materialize. So while it may be the case that if ultimately part of the paying for the bill it involves some taxes in California, and I think that's right that it will, and that taxes can vary a little bit year to year, or a lot depending on how you design the taxes, and that therefore you need to be able to have some money in reserve to deal with the pluses and minuses, that CHBRP probably overstates how much is needed there. Let's just say that. So that's one thing I wanted to share. I hope that wasn't, too geeky, but I want to share one other thing, or a few other things from CHBRP land. And hang on while I get that fired up. Go back to the CHBRP. Here we go. So we'll be there down to page 19 where all the action is. And so let's see, is it there?
Hey, Ron, while you're looking for that, can I just tell Paul that I like his background? So, I don't know where we got those, but we both got the same one. And Ron, I have a competing graphic I would love to show, to your Chaburp, but whenever whenever you're done, maybe I could share that one. It kind of, I think it's kind of way simpler to kind of wrap your head around. But
Yeah, no, absolutely. But let me just hit a few places where I think there could be some talking points, and then definitely let's show your graphic, because it's worth making some detailed points and worth making some big general points about the bill.
yeah,
So one of the things that I guess that Jaburp is trying to do is say, well, where are some things, where could there be problems, or where might be some uncertain things? And I think it's possible that some of these become sort of weaponized against the bill, and some are just straight up wrong. So let's point those out. So on page, I don't know, something like 19 of the Chaburp, under other uncertainties, I mentioned they say this, and I hit a few of these things. So the scale and challenge of the implementation of AB 1400 may result in unanticipated impacts in the following areas. So here's the first one: reduced investment in hospital capacity / investment if provider rates are set lower than cost. And I think that this represents a fundamental, I'm not going to say misreading, maybe an underreading or a non-reading or a misunderstanding of some key elements in the bill, because the bill identifies hospitals as institutional providers, and they're paid global budgets. And within those those global budgets are operating budgets, and there are separate capital budgets. So capital expenditures, things like investment, is not dependent on whether provider rates are low or not. It's not, in other words, this is a misunderstanding that relates to previous understandings of how a place like a hospital might deal with its revenues. So in other words, a regular way a business or a hospital might work is, if it makes more money one year than it spent, then that money is extra and could be used, those savings, I guess you'd call it, could be invested in some things. But that's not how the AB 1400 anticipates hospitals dealing. If they make extra money, that money goes to patient care in operations. If there's separate capital investment budgets. So
yeah, not to making the hospital look like a 5-star hotel suite. Which they do. They put a lot of money into aesthetics because they want the Yelp reviews. They want, and I think that what that brings up is a good point that I think that Ron, I'll let you finish, but it is some good. Like I said, I've been playing the devil's advocate role this past week, really thinking through these things, but I'll let you finish and we'll go into this a little bit later.
Just a few more comments. So reduced technology adoption. I don't think that's particularly likely to be true, but it is probably the case that technology adoption in California will be more aimed at the needs of the public's health than at profit. And that's one of the key changes that this bill, because it changes provider incentives. So I think that that's incorrect. So a disruption and upheaval in healthcare workforce, loss of jobs. Right now our system employs a lot of people in some jobs, for example, in a very complex billing apparatus, that maybe that effort could be spent somewhere else. And so I think it's right to say that certain jobs will disappear, but the bill is very committed to what's called a just transition, which is to plugging folks who lose jobs back into that, particularly in the healthcare system, doing things like actually providing meaningful healthcare to people, retraining people to be able to do that, and making sure they're supported in that time. So the efficiencies that a bill like this would bring to the California economy is almost certainly likely to be a big net job creator, not a loser of jobs. So reductions in healthcare workforce pay, I think that that's a complex statement. There will be negotiations on provider reimbursements that can have some pluses, it can have some minuses. It's sort of not entirely clear that that means any given institutional provider would change the amount it pays anybody. It doesn't take away anybody's collective bargaining rights. So I'm going to stop there, but I just want to say that the CHBRP should be read with a jaded eye. It says some things that I think are meaningful. It brings up, I think, some interesting points, but I don't think it should be taken at face value. And there'll be more work to do in answering, I think, some of the questions that it brings up. So let me leave my part there. Before we get to Dr. Bill's graphic, Jeanna, did you have any like key sort of CHBRP take homes that you wanted to share?
Yeah, just really quick. So like I chimed in, the reduced investment in hospital capacity, I do think we have to be careful with watching these guys. They will trim fat, and they're going to trim fat in the wrong places when we institute something like this. So we do have to be careful on where they're allowed to trim the fat. They will try to reduce staff. We've seen that anytime that they face financial issues. And CHBRP brought up a good point, but like, Ron was saying, we have to look at it through a jaded eye. You cannot look at this as law. This is just another opinion from some other nerdy people like me that just have different nerdy backgrounds. So I do think of this, but it also makes me think, and that's what I like. I like to think, make me think of the other end. What are the other people going to think, so that I have a conversation to bring back? So yes, we do have to watch how they trim fat, because they are going to do it. And if you think it's from the hospital CEO, CMO, which is Chief Medical Officer, Chief Nursing Officer, you think it's from the C-suite level that they're going to try and trim fat? Probably not. So we got to watch that. And then reduce technology adoption. I think what they're saying here, from my personal experience, I've been a subject matter expert that's helped launch quite a few different, electronic medical records, from nursing homes with point-click care all the way up to the granddaddy Epic. And Epic is far more expensive than some of the other lesser expensive medical record systems like Allscripts. And so when they say reduce technology adoption, I just hear that hospitals are not going to want to go with the big fancy Epic system. But if this is the entire state of California, they're going to want to be part of this. Trust me. Because this is going to give them bragging rights as, look, we were the EMR system that blah, blah, blah. So trust me, I'm not worried about the technology adoption. I think that they'll see this as a way to get in. And then reductions in healthcare workforce pay, like I said, going back to West, we are going to have to watch how they trim fat. But what I took home, and Ron has gotten a lot deeper into CHBRP than I have, and I admit that. But one thing that I look at is, I read through this, I kind of, it's like the mood goes, woo, it sends you on a mood roller coaster, because you're like, that's bullshit, and then blah, 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 and they're like, that's wrong. And I'm like, okay, well, maybe that's right. But, so I was on a mood roller coaster going through this. But one thing I do want to say that it brought up, and it has nothing to do with nothing too deep, but it does say that the uncertainty around, it says the uncertainty around immediate benefits, however, creates significant challenges for state implementation in particular. The evidence illustrates that maximizing performance and savings will require a very complex and intensive undertaking. And that sentence made me kind of think about my strategy talking to elected officials, by saying, this is going to be hard. This is going to require late nights. This is going to require a lot of work. And not everything can you expect us as activists who don't even get paid to do this stuff. Ron doesn't get paid to read all this stuff, and neither do I. It would be nice if they did, but just a little bit, something. But anyway, the people that get paid to do this, they are going to be challenged with something very complex and intensive. And so if you're telling me that it can't be done, I'm telling you that you're lazy. I'm done kind of sugarcoating it. I think that that's what the convention has done to me this weekend. I took all the sugarcoat off my tongue. So if you tell me that this cannot be done, it's because it's, we can't do this because of all the systems, it's complex, it takes forever. Yes, it will take time. No, it's not an overnight bill. The bill was 60 pages long. But that means that you are too lazy and you're looking for an easy out, that you are trying to kick the can down the road to the next generation to take care of. So, if the governor doesn't want to look at it right now, I guess he's basically saying, I'm going to kick this to my kids and let my kids deal with it because I don't want to deal with it right now. And that's how I'm looking at this. Eventually, somebody's got to deal with this. Just like a toothache, that first little a pain, you're like, oh, that was weird, my tooth hurt. And you ignore it. But if you keep ignoring it, guess what? The whole damn tooth is coming out. And now you have an infection all the way in your jaw. We're about at that point. We got about a little osteo going on in the jaw, and we need to address it. So we can't just keep kicking the can down the road. So that is what I mean, granted, yes, there is a lot of nerdy stuff in this we can get into, but I took away that one thing, which is this is going to be intense. This is going to be complex. And there are things that are going to come up that we haven't even discussed yet. But if we really dedicate to this and we get some elected officials and people in office who are willing to take it on, we can do it. It can be done. This says it can be done. It's not saying that this can't happen. It's saying AB 1400 can be done, but it will be complex and intensive undertaking. And I think all Californians deserve that. And with that being said, I saw Richard with your hand up. Did you take your hand down? Do you still have your hand up?
I did take my hand down, but it was while you were talking about Epic. I wanted to mention that let's not forget that Epic, also known as Health Connect in some places, its claim to fame isn't for patient care purposes. Its claim to fame is its ability to have providers pass core measures, which are like these made up measures, and that really all it has to do is ends up being for its billing capabilities. So the reason why Epic is so widely used isn't because it's a great system for the patient, it's a great system for the insurance companies and the hospitals to make money.
It tracks you, it tracks everything. It makes it very easy to code and put those billing codes in so that they can get appropriately paid. That's basically what we're saying. That's what we're saying. It is kind of user-friendly compared to some of the other monsters I've dealt with, but still. Anyway, I'm sorry.
Bill, do you want to fire up your graphic? And
yeah, so thank you guys for getting into the weeds on the economic analysis, and whether that analysis comes from the legislature itself or from other independent groups, and depending on the reputation of that independent group, the information that they share with the public can be weaponized, as you say, Ron. And so it is important to first consider where it's coming from, who commissioned that study specifically, and what the intent of it was. So, for example, you mentioned the group Healthy California. Before it was Healthy California Now, which is Healthy California. And then the state kind of adopted that, as you know, as the Healthy California for All Commission now. So now the Healthy California Coalition has renamed itself Healthy California Now because we need it now. But it actually formed into a formal group for SB 562. In particular, prior to that, there was no formal group. It was just some people got together once in a while. But it became a formal group under SB 562. And the principal citizen sponsors back then and even before then were the nurses, were the California Nurses Association. They put together a lot of terrific graphics and things. But you don't have to get into the micro kind of economics and policy details to see the weaponizing once this stuff is brought out. There are very macro details that are weaponized, and I think those are kind of useful to look at. So the slide I wanted to share actually was this one from the nurses, and you can see that that this is a figure that was used for SB 562. Which was only like, what now, 3 years ago, I guess, that we're talking about. So not all that long ago. Was it 2017? So 4 years ago. This slide is useful to read from the center out. So center up, center down. And but the punchline is down here at the bottom. Okay. But the number that's actually weaponized is this one up top. So the middle number is what we currently pay for healthcare, what we did pay for in 2017 numbers, which is about $368 billion per year in California. If we added everybody into healthcare in the state, okay, if we provided healthcare for all residents in California, including all of those benefits that we know would be included, whether it's by SB 562 or in AB 1400 now, that number went up to $404 billion. But when you put in the single payer financing and all of the savings, that number goes down. So what did the press do? You know, press like Sacramento Bee and other very, very kind of in tune to what goes on in the state capitol. They went after this number and said, look at how much more money it's going to cost us to provide health care to all the people in the state. They never talked about how much less it would cost with the model that was, proposed to be used for financing. They didn't talk about this lower number, what it would actually cost. They talked about the projected cost if they didn't change the financing whatsoever. So that's a very kind of macro, or kind of the most macro discussion of the financing that you could actually weaponize, into an argument. You can see the bottom line was it saved about $37 billion per year. And the population at the time of California was about 37 million people. That's what every study always shows, is that a single payer model of financing generally saves about $1 billion per million in the population. You can extrapolate that to any community. So, for example, the one I like to use is the city of Anaheim here in Orange County, about 350,000 people in that. That's a pretty good sized city for California. It's not LA, it's not San Francisco. City of Anaheim, 350,000 people, saves $350 million per year. Okay, statewide, we save $37 billion per year. Those numbers don't get talked about when if somebody wants to weaponize this other number and say we can't afford that. So I think that's kind of a macro look as opposed to CHBRP, which goes down into the micro.
And
thought I would share that.
No, totally. And I will mention that CHBRP actually mentions both the 331 number and the 404 number. And so 331 came from the Perry study, which is the financial study done at UMass Amherst. And that 404 came from the legislative analyst's office. Now, one of the things Dr. Bill is saying, and CHBRP discusses, is that a big study that was done mostly from UCSF, really looked at all kinds of single payer bills over all kinds of time, and they consistently save money. And in one conversation we had with the main principal investigator in that big analysis, Dr. Jim Kahn, I'd said, hey, what about the 404 figure from from the LAO, from the legislative analyst's office versus the 331? He's like, well, in my study, we couldn't really use that 404 because there was no methods ever presented from that very short kind of legislative study. It was literally like, take the amount we spend per person and add in the uninsured, and that's the total. And so it just so people know that there's numbers that are good and actually have some research behind them and real analysis, and numbers that don't have that. And people will turn, I guess naturally will turn to the ones that make their case better. But anyhow, that's where we are today. Let's go to a question that Leland put in the chat. And it touches on something that was also brought up in the CHBURP. So I'm going to read the question and we can talk about it a little bit. So it says, since over 70% of healthcare costs are already government covered, is the money required for our underfunded education system from the new tax revenues needed or the total taxes revenues needed for healthcare for all? And then I asked him a clarifying question, which is this related to something called Prop 98? So Prop 98 was a ballot proposition that in its last form, it was passed, I'm forgetting, was it about 2010 or 2011, something like that. And it was meant to protect the education budget in the state from the austerity that has been imposed on our state by bad tax law from the 70s, like Prop 13. And it said, well, any new big taxes like 40% of new revenues have to go to education. And so I would offer a couple answers to that question. One that's more about constitutional issues, and one that's more about observations about expenditures in single payer systems and countries that have single payer systems. So on the first front, it is not clearly the case that there can't be sort of legislative workarounds around the Prop 98 limits and other similar types of things like the GAN limits. That can be worked around. Another thing is that it's still likely that a ballot initiative will happen at some point related to a single payer bill in California, in which case those things could be taken head on. And then the last two-part answer to the thing on education spending. When we look at countries that have single payer health systems in place or universal health systems, they spend less on healthcare and more on social spending and the social determinants of health, including education. So that's observed in most places. And I think California would be like that as well. And the other thing is that right now, if you do a deep dive into education budgets, you'll see that one of the big costs is, guess what? The healthcare costs of the people who work in the education system, including pension liabilities related to people in the public educational system. And that we can do incredible work freeing our school systems from some of those burdens through a bill like this one. So those are some of my thoughts there. Anybody else or
I just wanted to add about the Prop 98, Prop 4 dance. Going back to the intensive and complex undertaking, we found out about Prop 98 and Prop 4, the GAN limit, only a couple weeks ago, where it was really brought up in a heavier capacity. I think someone murmured it a long time ago. And back to that complex undertaking, this is part of that web that is tied to this, and we can get around it. One thing that was brought up is that, well, is Cal Trust actually part of the general fund? And I'm like, man, is it? Because we are saying CalCare there will be a CalCare Trust fund established. And so is CalCare Trust actually considered part of the general fund, which is affected by Prop 98 and Prop 4? Question. I have not heard a very straightforward answer on that yet. But yeah, I did see that question too. Thank you, Richard, for putting that in the chat. From Harold Huggins. I'm sorry. So I want to go ahead and just go to that really quick, because it's been waiting for a while. And he said, have you looked at litigation action against the state because affordable health care is a civil right? And I felt like that kind of ties in somewhat to what we're talking about right now.
Yeah, actually, I had something to add to Harold's question, which is, you know what, we actually have the current system is separate and unequal, and it has apartheid-y like characteristics, and or let's just say makes a kind of healthcare apartheid in the state. And we're not the only people who've observed that. For example, or lots of people have observed that. So one organization that has a long and storied history of looking out for the civil rights of Mexican Californians, Mexican Americans in California, and it's called MALDEF. And MALDEF, Mexican American Legal Defense and Education Fund, has an ongoing federal lawsuit against Medi-Cal in California. Because because our current system, which has sort of a really kind of impoverished tier for helping people who are poor in the state that is badly underfunded, doesn't serve people well. And so there is active litigation against the current situation. Litigation doesn't necessarily create a new healthcare system, though. So leave that there.
Yeah, that goes back. Complex and intensive undertaking. If AB 1400 were to pass, I do expect lawsuits to fly the following day. So, you know, just passing this bill is not the end. We will have to defend it for probably many years until they get it through their thick skulls that this actually works. So, you know, I definitely expect that people, hell, the insurance companies are probably already writing them. They have the bill, so they already know what to write on. They probably already have their lawyers going through and preparing the lawsuits. They're just waiting to see what we do. But, you know, I think that it will be a big undertaking, and that's what we have to challenge our elected officials to do, because we can only get so far. We cannot get onto the floor of the Assembly or the Senate unless, well, no, I'm not going to go there. Anyway, do we have any other questions? I'm not going to go there.
I see a Paul Newman question.
Paul Newman.
You actually,
like me to read it?
yeah.
Sure.
All right. Would the resistance to AB 1400 from the State Assembly and Senate be more about private insurance industry threatening representatives, or are they truly for the ACA? The New York Times in the opinion section shows the rest of the world are highly successful with single payer. I mean, it's all over the place, you know, that single payer healthcare is successful and it works. And there's so many millions of arguments. What is going on?
You want to know one thing coming off of this convention that Ron and I were talking about before we got started is the lack of depth in the party. People just don't think. And I think that's, I mean, yes, the lobby money is mad real. As you saw, our convention was sponsored by the California Medical Association, the California Dental Association, pharma. Yeah, it was sponsored by some heavy hitters, which I was just like, I'm surprised it stayed. I'm surprised AB 1400 stayed on the consent calendar. I'll just say that. But at the same time, it's a mixture. I think that they are not thinking downstream, which I love to say, are we thinking downstream? If by building the dam here, who are you hurting? And, you know, are you thinking that far down of who you're hurting, who you're passing the buck to, who you're, you know, and then also, is that money worth it? Because I mean, you know, most assembly people, I think just starting your freshman assemblies are making six figures, low 100s. But somehow we've got multimillionaires in the assembly. And I'm like, even if you worked and didn't spend a dime, how are you a multimillionaire, you know? And so that's where we have to really focus. It's like, yes, we know who's taking money. We know that. But also it's like trying to figure out, you know, what is it? Is it lack of knowledge or lack of will or both? That is making them just vehemently do this. And I think one of the things Miguel Santiago told us was that he faced so much hate when they introduced this bill. Lack of spine, yes. And they called him a communist. And if you guys, and I was like, and I had to comment, and I was like, if they called you a communist, then hell, I don't know what they'll call me. But that shows the lack of education that people are just throwing these words around. So I'm like, you guys really, we're not dealing with, to me, the smartest people that are up there. Honestly, the ones who are opposing this, I would say, have you even read it? but it goes back and forth. Like I said, it goes back. The point is, they're the ones in power, unfortunately, and they are our gatekeepers. And getting around them is going to be a challenge and a half. So I really, when it comes to the strategy of that, and, I kind of am trying to just get to that what do you want question. Like, what is it that you want? Name your price. Because maybe we could start a GoFundMe. Help me buy the politicians. If I can go fund healthcare, why can't I go fund? Why don't we create a lobby? I'm actually might be a little serious about this. I may create a lobby through GoFundMe about buying politicians so that we can get to pay them off for single payer. So if United Healthcare or if Anthem paid you $10,000 to your next campaign, maybe I can GoFundMe that $10,000 and we can pay you. Thoughts? I'm just sorry.
I want to jump in here because you're doing a terrific job, and I just want to add to that. I don't know if you heard, if you happen to be in the PDA, Progressive Democrats America, we had our convention luncheon, which is, I say that with tongue in cheek because we've always offered a convention luncheon as an alternative to the party's own convention luncheon, because usually there's like some high dollar dog and pony show. We actually have people we think are kind of, like rising voices that we want to give, platform to. So people like Miguel Santiago, well, we had Sydney Kamlager at ours, and she dropped the F-bomb a couple of times, on Saturday, saying that this system, meaning healthcare, because we had her hunt for healthcare with my good friend, Dr. Betty Valencia from the city of Orange. She, Sydney said healthcare is so effed up, in this state, in this country. I mean, she dropped the F-bomb, so I think there are people like Dr. Saradine here was saying, that the party is completely beholden to these financial interests who finance their campaign. I 100% agree. But there are some people, who are inside and outside at the same time, like perhaps Miguel Santiago and Sydney Kamlager, who are trying to act on behalf of the people. And so I think it's worth our efforts to get behind them as much as possible. How do we get behind them? I think behind's the wrong word. We were talking about this earlier. Underneath is better word. Support. We were saying it's kind of like whack-a-mole. Who's going to be the next mole to pop up their head? Is it going to be Speaker Rendon? Is it going to be the governor? Who's it going to be? Well, if we just raise the underneath, then guess what? All these moles come up, and then you can see them all. But as opposed to the metaphor, what I mean by that is that we raise awareness, we engage the voters to the point where they can no longer ignore us in favor of the money, because the other thing they respond to besides money is votes. They need our votes, and you can lose election. You can spend a ton of money and still lose an election if you don't have the votes. So I think doing stuff like this, like holding a forum, is doing exactly that. We are raising awareness, engaging voters, and we're giving platform to those voices. So,
exactly.
And that's how we get that influence, that corrupting influence of all that money out of the party, and allow good people to do the work that they can do on our behalf.
Yeah, so I definitely shout out to Senator Kamlager. She's my senator. She was my assemblywoman. And I will be honest, she and I had a conversation about single payer before AB 1400. This was back in November. She and I, at some point, like right after the general, where we talked about this probably for an hour. And I told her a new bill is coming, and, I kind of need you to support it. And she actually appointed me to a healthcare advisory committee for her personally So I will be working closely with Sydney. I'm very glad to see where, how she's evolved on this topic and how she's becoming more boisterous. And she's also submitted other bills currently to, and one of them, which was recently killed by Jim Wood. So she definitely has it out for Jim Wood. And so, I think it's like Street Care Act, where she was trying to make Medi-Cal more accessible for homeless people. And while, like I said, that's not AB 1400, but she's making action right now to make things happen right now, because we know what we're doing is getting things this is going to take a while to get done, but we do need to help people right now as well. So there are a lot of like little bills that are up that need to be supported too. And I told Ron about this when I was looking through the health committee calendar, and I was seeing tons of bills listed, tons and tons of little bills listed. And I was like, holy shit. I was like, maybe I need to look at some of these other bills too, because while we're working on the big bill, the bill of bills, there's some things that maybe we could squeak by right now that will provide help for people right now, because people need help right now, not in a few years, not when we get AB 1400, but like right now. So I just wanted to go to something that Leland had put in the chat about, and this is a very good point. What if we can't get the waivers? How do we bring forth the, how do we bring forth, excuse me, I'm sorry, the chat keeps moving. Okay, it says, if the waiver for federal funding cannot be done, can healthcare for all still work since the federal funding is all for healthcare anyway? Can healthcare for all be supplemental for Medicare, Medicaid, and the ACA to cover dental, et cetera? And can it still replace private insurance for the ACA and employer plans? Now that's a deep one that, we gotta, unpack a little bit.
Yeah. Well, I'd be glad to weigh in on this. So, we know what it's like. We suffered through this under Trump. We saw that we stood at the edge of the abyss, and some would say we even went into the abyss under Trump, and that's why we lost 570,000 people nationwide, 61,000 people in California due to this pandemic. They did not have to die. We did not have to have these severe losses. And when Gavin Newsom applied for the waivers when he first took office, Trump could have granted those Section 1332 waivers of the established law of the Affordable Care Act at the time. If Trump had said, hey, California, go ahead, secede from the union. The rest of us, we're red states, are going to be fine. We're going to do our own thing. Go ahead, California. Go off on it, do your own thing. Well, maybe Newsom would have done his own thing, but I think he was betting on Trump not complying, not granting the Section 1332 waiver. So that's basically what it was like. Now we have what everyone thinks is a favorable administration to grant those waivers. Now, Newsom seems to be not wanting to apply for them. Why? I don't know. It doesn't seem to make sense. We can all kind of come up with theories and conjecture on that subject, but that's another reason to want at the federal level to want to pass Ro Khanna's bill, the State-Based Universal Health Care Act, because then we don't have to be dependent on whoever's in the White House to grant those waivers. Once it's a matter of federal law, that states who want a universal healthcare system of their own and meet, said statutory requirements, then it takes it out of the hands of the current president and their Department of Health and Human Services. So that's a reason to be behind that piece of federal legislation, which Ro Khanna will be reintroducing. But it just means it's just part of the work that still has to be done here, and why the movement it has lots of different things we're trying to accomplish, not just the passage of a single bill like AB 1400.
Right. And I just want to emphasize, and I'm going to continue to drive this back. Passing AB 1400 allows us to explore. I like to call it, it's more than an exploratory bill, but it is an exploratory. It basically gives us, it's like almost like it allows us to explore the final frontier. This is the Starship Enterprise, and we're getting ready to take her out on her maiden voyage, but we don't know what the hell we're about to get into really, but we're going out there. And right now, historically, nobody has let Enterprise go out on her maiden voyage. And yeah, I'm trekking it out right now. Don't judge me. Star Trek was one of my mom's favorites, so I remember watching as a kid. So but AB 1400 is really trying to take Enterprise out on that maiden voyage. We're trying to go on our maiden voyage of seeing what is out there in that final frontier. And what do we find? We may find that, oh shit, it is scary as hell and we can't do it and I'm heading back. We're heading back to Earth. Or we may find a better and brighter and more beautiful future, and something that we are willing to continue to explore because we want to keep going. And that's what AB 1400 is. Yes, honestly, Leland, to answer your question, yeah, we need the hell out of those federal waivers. That is a big chunk of the financing. I'm not going to lie, I won't sugarcoat that either. But the way that we deliver it, the way we convince people to support this, and by saying also that we can't implement anything until we have that taken care of. So if we don't get the federal waivers, we also have to come up with that, what's plan B? But that doesn't mean that we don't need to pass AB 1400. AB 1400 just lets us start the maiden voyage. It allows us to assemble our first crew. It allows us to get everything and get Scotty and everybody together so that we can start our maiden voyage. And right now, for years, for decades, they have not allowed us to do this. They have not allowed us to go out there. They're allowing Elon Musk to go check out Mars that has nothing on it but dust. And you won't let me go and see if I can find something better for healthcare. So that's kind of like what I'm saying right now with AB 1400. I keep bringing it back down because I want people to understand that this bill, passing this bill, supporting this bill does not mean that we will completely wreck the healthcare system as we know it the following day. This means that you are letting me and a couple of other crazy ass activists who are going to dedicate probably our life to it, start exploring this with these politicians. And this is going to allow the governor to appoint a board, which I hope is progressive, and committees to be formed so that we can really start peeling back the layers of that onion. Because right now, all we're doing is kind of doing a philosophical maybes, but we can't really start exploring it until we get this bill passed. So that's the reason why we need this bill to get passed so that I can take Enterprise out on her maiden voyage, or at least be somewhere in the lower decks, probably, because I probably won't be on the upper deck because I'm just like this big in this space. But I would be on the lower deck for sure. So I'm sorry to kind of pontificate about that, but that's literally what we're trying to do here, is really just go out. Yes, Dr. Bill.
So I don't know if we can kind of switch gears a little bit in the discussion.
Sure. I don't see any more. I'm just checking. I don't see any more questions. I mean, look, I don't see anything on Facebook either, so we're good.
Well, I was just thinking that since somebody brought up, because we just suffered through this virtual online Democratic Party convention for the state. A lot of us here in this meeting space. And it was brought up that there were corporate healthcare sponsors, including, in my opinion, one of the worst, which is the California Medical Association. And I would just like to bring up, as I do every chance that I get, and I don't know, maybe Dr. Richard Wynn, who's here with me, can give his own perspective. But as a practicing physician in California, I never in my career, I'm now 4 years, almost 4 years retired, but I never belonged to the CMA or the AMA or the Orange County Medical Association for that matter, because I always recognized them as not having my interests at heart. And what are my interests? The interests of my patients, because I felt like they were advocating for the really high priced, mostly surgical subspecialties, and not kind of, the real bread and butter kind of general and primary care, in particular, not for, like, say, pediatrics and mental health providers, basic OBGYN, internal medicine. Some of us, yes, we were subspecialized in emergency or intensive care. But Richard, you are intensive care pulmonology, right?
Correct.
So, and managing ventilators for COVID patients and, all of that. So thank you for providing that care to people. Yes, our hearts to your heart for that. And so what's your feeling about the CMA? I mean, it looked like there was hope recently for the American Medical Association and the CMA, that it is kind of with the influx of younger, newer physicians who do see the value of promoting a medical association that really has the patient's interest in mind. What do you think about that and its relation to getting single payer in California?
Right. I agree with you in that up until more recently, I have not been a part of AMA, CMA, or LACMA, Los Angeles County Medical Association. And that's because a lot of their interests do not reflect those who truly are interested in patient care and whatnot. And for them, I believe, and I think, I wish Sarah was still here. Her husband, actually, Dr. Omerdine, has been working with CMA and LACMA quite extensively into trying to change their sort of mantra, to change their culture there into becoming more patient oriented. And he said, as he says, it's been quite a task. But he says slowly but surely he's starting to gain a little bit of traction there. So I actually recently joined CMA and LACMA this year to try to help him. And I believe Dr. Ron Birnbaum is going to help us as well in this task of trying to get them to be more supportive of legislatures such as AB 1400.
Infiltrators. You're infiltrating.
Hey, I am the queen of the infiltration, so I'm mad respected. Just let us, I mean, if you need the nurses to come, because, we smack you doctors around all the time, so we can come in there and smack you guys around.
That is definitely true. That and we need it most of the time too. So, but yeah, that's what we're working on. One of the big issues is that these, CMA, a lot of the staff there, a lot of the membership there are people who have vested interest by the insurance companies, and so there's a big conflict of interest there, and that's what we saw at the convention. It's that same money that is pouring in and polluting everything.
Yeah, you know what? And as we call for more money to come out of the party, this is a whole nother conversation, but there was a heated post in the California delegates group, which I'm not gonna say who said it, but it basically, someone had called out the donors and the supporter, the sponsors, sorry. And, the more older / party side decided to come out and they're like, well, you guys don't know, you guys just want, how are we going to make money? How are we going to do this? How are we going to do that? I'm like, well, charging $100 for a little can of wine and some peanuts that's one way to make money. But we do acknowledge, I just want to take this time to say, we do acknowledge the fact that the party will need funding mechanism as they decide to take less corporate sponsors. And we are willing to fund the party by making small dollar donations, but we need proof. Like, I'm not, and I've said this to the party before, we have to, see that our money is going to go towards fighting for the things we want and not just, statements of principle. And so I digress on that. But one thing you guys are brings up a good point of what we were talking about before. And this is kind of tying back to AB 1400. As in a previous office hours, it was brought up that if Governor Newsom wanted this, he could make it happen, right? And one thing that is true, if Governor Newsom wanted this, he definitely has the power to pressure from above. So we would put, the pressure, like me being in middle management right now, I get pressure from my employees that are under me, and I got pressure from the top. And so I'm being squeezed. But if we wanted AB 1400 and the governor wanted AB 1400, then yes, the assembly and the legislator will be squeezed to do it. But one thing that I will acknowledge that is different is that the behemoth that we are facing is not the same as when Medicare was passed in 1965. And I acknowledge that because I am not unreasonable. I'm not irrational, and I'm not unreasonable. I know the barriers that are there. And I looked up, I just want to share this with you guys because I looked up the kind of like a little timeline of, insurance here in California. So I thought it was a good graphic to share, and it seems like this is a good time to share it. And so I'm going to share my screen and show you this little graphic. And this is only to 2009. This is from the California Health, oh my God, the CHCF it's a California Health Foundation, I'm sorry. And it shows you the timeline here. So starting out when kind of like 1929, and I'm sorry if this is so small, I'll try zooming in here. Okay, can you guys see it? Okay, a little bit better. I'm looking at it on Facebook, so I'm trying to also see, like, can I see it on Facebook? So in 1929 is when we really start this timeline, right? We have the Ross Luce Clinic, and there's kids playing in the background, I'm sorry. And then, it opens in LA as a prepaid group for physicians who provide medical care for workers in the city's water department. So, LADWP. So 1929, we're coming just out right past the Great Depression here. So we're kind of in the midst of the Great Depression going on, but we know that, so at that point, Great Depression, we're still starting some type of health group, even though it's prepaid. Now, here comes 1937, a name we all know. California's Blue Cross Hospital Insurance was established. And then the following year, here comes Blue Shield, the physician insurance was established. And then we truck along for about, seven or so years, and here comes Kaiser Permanente. And, they were just offering, to the public if they serve, dam, steel, and shipbuilding workers. So now we skip ahead about 14 years. And so 14 years, that was it. And so here comes 1959, the Federal Employees Health Benefits Act, 1962, CalPERS, and then here comes the big daddy, 1965. Medicare and Medicaid were established. So here we are to 1965. So how many events do we have? We have, let's see, 1, 2, 3, 4, 5, 6. We have 6 health, major healthcare insurance or some type of insuring type event that occurred up until 1965, where Medicare was established. So now we have Medicare, and then I'm just going to scroll over. So from that point, look at everything that's happened. And so Lyndon Johnson had this stuff going on. Granted, this is just California level. This is not on the federal, but he had like the Federal Employees Health Benefits Act to deal with. And, so he had just these little humps to get over that deal with when it came to Medicare and Medicaid. Now we have these humps to get over. Some of these, of course, are not necessarily bad. But then here comes HMO, here comes Knox-Keene, here comes PPO, here comes, boom, boom, boom. Like it just was a free for all during this time. And then all the way ending with, now we have the ACA, and then, but managed care is still the bulk of what people have here in California. And I didn't even know what HMO was until I moved to California from Indiana originally. So I was putting that out there. But, I just wanted to share this timeline because you see here 1985 to 2005, consolidation of health plans. So now we've got the monopoly effect going on. And then, so we have this underlying thing going on, where the healthcare system is becoming that bowl of spaghetti. So in the last, since let's say 1970, or actually we could say when Knox-Keene really came in, 75. So from 75 to now, the spaghetti came. And now I just wanted to paint that timeline so that you guys see how much in these last decades, what is that? I mean, even I want to keep saying 30 something years ago, but that's way more. That's like 50 something years ago. So, the last 50 years have really had a big impact in healthcare. And, I wish it was all to the benefit of the people, but we know that several of these events that occurred on this timeline are not. CHIP was established in 97. That is to our benefit. But, the California Patient Bill of Rights benefit. But then, HMOs, Medicare Part D, it sounds like that would be great, but Part D kind of sucks too, because you got to pay for it. So I just wanted to share that. We can have any thoughts, but AB 1400, we will have to kind of face some of these humps. And like I said, this is just an ugly system that's here. And I just wanted to show that timeline. I'm sorry on Facebook if you guys couldn't see it, if it was too small. I will put the link to it in the chat here. If someone could post that in the comment on Facebook, I appreciate that too. But I mean, like I said, I just wanted to share, not really a big informational thing if you didn't know, but I found this actually a while ago, and it was just really kind of eye-opening to how this healthcare system became the bowl of spaghetti it is.
Gina, that was really interesting. But can you explain to me why you see it as humps CalCare has to get over?
Because there's certain, like, for example, the opposition. So the opposition thinks that these new programs as they rolled out are actually good things. Like, well, look, we expand Medicare here, we started this here, we did that, we did this, and they're going to use that as, oh, look what we've done. Look what we've, and so they're going to think that that is enough. And now, especially with the ACA is like, that's the big, like, but look what we have the ACA. And we know none of that is enough. And so I also show that to say that we have to keep peace, like we're going towards the same goal here, right? We keep piecemealing it though. We keep like, it's like, oh, we found another hole. Look, oh, children aren't covered. So let's plug that hole. So why not just like, let's just do it all together. It's already in a sense there. And the timeline shows it's there, but it's going to be a hump because they don't see it like that. They see it as the fact that we keep making things better on this timeline. I see it as a hump because now I've got it. Well, that you have the Knox-Keene Act, Managed Medicare Act, the federal health, all these these acts that will they require, certain amendments? Do they have to, how do we work in AB 1400? Does that step on that toe? Does it do this? Does it do that? Which we're kind of coming up against with Prop 98, Prop 4. So that's where I'm saying that it's that bowl of spaghetti, but I was also showing it to show how much the healthcare system has become convoluted since that passing of Medicare as well. So like I said, some good things, but a lot of it allowed for this mess to occur. And I mean, and like I said, I really didn't have a whole big point of showing, I just thought it was a good infographic too.
So like I've seen, yeah, that's a really great point. I think in other social justice movements, so one of the ways to destroy a movement is to divide the people in the movement, right? To create dissension within the movement. And I've observed in other social justice movements that, they'll have infiltrators that will make obvious divisions between people, and it's a little bit more obvious. And I find that that kind of getting our people divided, like one of the stealth oppositions that I see it as is like, let's say you have a foundation that's actually funded by an insurance company, and they're like, you know what, we have a group of people over here that don't have insurance. Let's give them a little bit of insurance. And those people are like happy to get it, right? But what that does is it pulls them away from the bigger fight of single payer, where single payer would include everybody, not just this little group over here. So, right. So not just the people who can afford or can't afford and are on Medi-Cal, not just children, right? And so then we lose them from the movement. And I think that the way to see through that is anything that keeps the insurance companies in, that's your opposition. So anything that's covering children, let's say, but it's keeping insurance companies in, it's the opposition. CalCare would cover everybody from birth to death, documented, undocumented. You know, and so that is, and then we lose those people. They'll fight for this little piece over here, and we have to find a way to keep coming back that CalCare covers everybody.
Right. And you know, and that's the thing too. You know, getting past those, because they are going to talk about expanding. Like I was on a call with someone and they support it, but they of course brought in public option. Well, we will get more support if we also say that it could be a public option at first. And yeah, I know that look, but you know, I totally get it, you know, with basically how we feel about it, but these are the conversations that we need to be having with our communities about public option. Hence the reason why we do the after hours office hours, is so that we can disseminate what a public option is versus, and why that it's not the solution versus why, you know, it possibly is. But I'm going to go, Richard, I see your hand up, so let's go ahead and take your question.
No, it's not a question. It was just a comment, I guess. I think that's why it's important for us to not only talk about the uninsured, but the underinsured, right? And then also talk about how CalCare or AB 1400 and this concept of a single payer health insurance is ultimately gives us healthcare equity. You know, we're not just giving people some insurance, we're giving everyone the same level playing field. We're, you know, there's that meme that's around with the kids trying to watch baseball, right? We're not just giving them little boxes to stand upon whether or not they're able to see over the fence or not. We're tearing the fence down. We're letting everyone into the game. We're letting everyone see the game. And I think that that's an important thing to make note for people to understand, is that, you know, this is not just about the uninsured. This is about the underinsured. This is about creating equity.
Exactly. And that's why I like to call it a health equity bill, not equality. Everyone truthfully does have access to care if you can afford it, or if you meet the financial income requirements, or if you do this, or if you do that. So yeah, you could say there's an equality there in a certain word, if you really want to use that word equality in a very bad way. But equity is the important thing. We're trying to create an equitable healthcare system so that you don't feel that you're not getting the right care because you're at a clinic in Compton, and that everyone has to go flood to UCLA because that's where they feel like they're getting the best care. That is not right. Why do you have to go to Westwood to get better care than if you live in Compton? You know, why do people, it goes back to poverty is not a crime. Okay, and that's what this current healthcare system punishes us for living in poverty, punishes us for being poor. And people cannot say it's not because they don't try. No one wants to live in poverty. Nobody wants to not have health insurance. But, well, here we are. So I just wanted to, you know, it's a health equity bill at the end of the day. James, I see your hand up.
My feeling is that the politicians, they don't believe what they say. They know how the thing works. I think the only way we're going to tip them over is more real life consequences for elections. We've won the public over, apart from a handful of puppets who don't understand how the thing works, who think it's going to bankrupt the state. The public generally supports it. So part of the mobilisation will be vote against the incumbent. Obviously, we need to keep hacking away at the politicians, but they don't need convincing. They need punishment. They need being voted out of office. That's the only thing they're going to understand, because we're not telling them anything they don't know.
And I will say, yes, I agree. And the problem is, one thing I have dealt with, and several of us have dealt with, is that it's like we can't win when we have so much money to go up against, you know, like, you know, that's the problem, is that we're facing this. Yes, we need to get definitely some progressive people running against these moderates or Republicans who are not just hell bent on stopping the democratic process, but they're hell bent on helping people. They are literally just holding that position because it is financially beneficial to them. And we need to tell them that, yes, you can be touched. and no, this is not a, you don't get to live and die in this position. And so I think that that is right. If you are not going to be on board, or at least not even open to it, if you get the right evidence or whatever it takes, then yeah, you need to go, because you are stifling the innovation of California. And that's what I also bring forth. Like I often take that compassionate argument off the table when I'm dealing with these types of people, because it's not compassion that I'm looking for with you. I'm like, fine, if you want to talk ego, okay, let's talk ego. I'm like, you are stifling the innovation and the progress of California, whether that progress be considered lefty or socialist or communist, or whatever. You are stifling progress. So imagine if Henry Ford never got to make that Model T. Imagine if we never actually got the interstate system going. Imagine if the Wright brothers just gave up after that first plane because they had people that would not allow them to keep going. So that is what I challenge them with. Are you trying to tell me that you do not benefit from the nice cars that we have, the airplanes, flipping electricity, all that stuff, all that required innovation? So I literally go back to them. I'm like, you guys are really being your own like, executioner here. I'm just trying to help you out. At the end of the day, I'm just trying to help you save yourself. Anyway, Dr. Bill, you got your hand up.
Can I just finish
Oh,
off?
sure. Yeah, I'm sorry. Go ahead.
Yeah, what I might add is the Koch brothers said, gee, it's getting harder and harder to buy an election. This was after the 2016. So even their dollars, they used to just buy some TV ads, get some robocalls and be done with it and win the Republican seat. So the tide is moving. And I've always been arguing the financial side, savings, so that they look stupid when they start asking, how do we pay for this? Anyway, next person. Thank you so much.
And I just will also add, if anybody proved that money doesn't win elections, let's talk about Bloomberg. Bloomy spent $500 million on a presidential primary and didn't get anywhere. Tom Steyer, and I agree with Tom on a lot of climate stuff, but the presidential election, he blew billions and didn't get anywhere. So like you said, the tide is turning, and no, you cannot buy an election anymore, at least not in California, for the most part. Anyway, Dr. Bill.
Well, I want to kind of bring this back around to, political reality and what may be, the lesson, as painful as it is to go and try and actually get something out of these conventions, as much as we can. But I think that when you go and you see kind of the dog and pony show, the pep rally nature, it's all talk of process and personality and very little about policy. It gets very frustrating in a hurry. I actually posted every chance I could in the chat. This little thing I put in the chat right now, which is my COVID reality check. Whenever it seemed like everybody was straining their arms trying to pat themselves on the back for things. I put in there that, of the 61,000 people who have died in California from COVID, we could have saved 24,000 of those lives, if we had a single payer system. That's 464 lives per congressional district, 307 lives saved, mothers, fathers, sisters, brothers, cousins, uncles, aunts, co-workers, lives saved if we had a single payer system. That's public health science saying that, and President Biden says he believes in science. So so they ought to believe in science and start acting on the science. So I think you're right. The science is behind us. We have won the public argument. We just need to get more people kind of clamoring, to make them do the right thing. And I'm thoroughly convinced. If you look back in history, you don't have to look too very far. I mean, you can look, say, at the anti-Vietnam War movement, for example. That war would have kept going on, God knows how long, if there wasn't, the Chicago 7, and the SDS and all those other groups that were, and Dr. King. Dr. King was an outspoken critic of the Vietnam War. So, I mean, there are lots of movements that have created the political change that caused the social change that we're looking for, and that's what we're doing here. We're talking about it, and we need to keep raising awareness in every way possible, just to keep building that. With street heat, with town halls, with movie showings, whatever we can do to raise awareness to where the people just aren't going to take it anymore. They're not going to be satisfied with the status quo.
Absolutely. Erica, I see you have your hand up, and then I have something I want to bring up after, because I know we're getting to the last 20 minutes of our office hours.
If you guys discussed Shabirp, can we discuss it again next week when I'm here, or fill me in later?
Well, I mean, it's being recorded too, so the recording should be live too. Ron had to step off at 6, but he did go into it. And actually, what I did want to discuss kind of does come back to Shabirp. So not in deep detail, but since we have 2 docs on, Dr. Bill and Dr. Richard Wynn, one of the things that Shabirp talks about, and I have actually thought about this too, having, the actual application, from nursing practice and then being in healthcare since I was a wee tot of 17 years old. How do we, if we give access to everyone, and this is also brought up in Shabirp, how are we going to address the utilization or overutilization when people, because that's what they're saying, that it doesn't address how to, handle that uptick in utilization. And Erica, I know it doesn't sound like it makes sense, but actually it does, because we have a lot of hyper utilizers, and you have to account for people who haven't had access to care, who may be coming in extremely sick. And that's what they do. That's what the current system is causing right now, people to be at home being extremely sick. So what could have been a simple fix is now going to be a very costly, complex fix, because they have been either, withheld from care or wasn't able to afford having care. So, I mean, Dr. Bill, Dr. Wynn, how do you guys think, and you guys know these types of patients I'm talking about, granted, we know that they're in the big bucket of healthcare, they're actually not that big of a drop, but this is going to be something that is brought up in opposition, especially since it's mentioned in Shabirp.
So I guess I could go first. I've heard the health policy people and, health policy economists answer this by saying it's in there. They have factored that into their economic feasibility studies. All those studies that we talked about, like the other studies besides the ones sponsored by the legislative body themselves, like the Perry study, like all the studies that Jerry Friedman has done, like every time it's been introduced into Congress, which has been many times now, since Representative John Conyers Jr. of Michigan first introduced it like 20 years ago, as the single payer bill. Actually, in California, I found research going all the way back to the year I graduated high school, which was 1971. Speaker Willie Brown and Senate Pro Tem President John Burton introduced the universal health care bill. So every time they have an economic feasibility study, and every time they factor in, kind of you're calling it overutilization, they just say it's an increased demand that's brought on by opening up complete access. There are other factors kind of that negate that, as well. So that, for example, that people currently use the system who may not use it so much, they're kind of overutilizers at the moment, who wouldn't use it so much necessarily, once it's kind of open altogether too. So it ends up kind of balanced out by a number of economic factors in terms of demand. One example is when things are open up at primary care, they're no longer going to emergency care. Okay, and emergency care is much more expensive, much more inefficient. So that was George W. Bush's solution to universal health. Just go to emergency, right? What a dumb.
I want to kill people who say that.
Yeah. So it actually is less expensive to open up primary care, and people end up using specialty care less, and you end up with much more preventive care that offsets the costs a great deal too. So that's the kind of thing that on balance ends up offsetting costs for your, quote unquote, overutilizers. And actually the number I've seen have made it, what's the term? I'm blanking on the term when things pay for themselves within, like, say, a year's time. It pays for itself.
Cost neutral.
Cost neutral, or
or self-sustaining. Self-sustaining.
You're getting there, getting closer. But anyhow, so it's kind of a break-even point where it actually breaks even. Even people say, well, it's going to take a few years before that happens. It doesn't. It starts happening right away, and people don't want to go to emergency. They really don't. They don't want to go to the doctor at all. If they don't, what happens when you go to the doctor? You get poked and prodded and told to take your clothes off. That's not a fun thing to do. It's not Starbucks. It's like, so no, that's actually, most of it is a myth. But anyhow, I've gone on too long. Maybe Richard.
Yeah, I just want to, you brought up a good point. Richard, you want to add to that?
Yeah, I mean, I'm certainly not as well read as Dr. Bill, but I can base it off of my experience. And the fact is that the majority of our healthcare spending occurs at the end of life, when disease is at its greatest, right? And that's what we see. We see the patients who come to where I work, the intensive care unit. They spend thousands upon thousands of dollars on ventilators, on machines with high level care. When you have greater access to care, they're able to see primary care physicians more often. They're able to be diagnosed earlier. Their disease can be managed earlier, and so it doesn't get to that point. And so that's going to give you a lot of cost savings, in my opinion. Less patients going to the emergency room, instead nipping it at the butt, having greater preventative care. Those types of things will actually reduce our healthcare spending. And so I think that, it's a little bit of a myth as to if you open up this door to everyone, you're going to have everyone rushing into the hospital. No, people are going to be rushing to see doctors and stay healthy. That's the whole idea. And
I agree with you. I think that the reason why I bring that up is because even in my world, where I have explored and probed, I've dropped this single payer question in certain conversations, and they bring to me, what are you going to do about patients like this? Look, they've been admitted 13, 14 times. And I'm like, well, that's just 1 out of millions, truthfully. But at the same time, you're right. What are we going to do about that? And this goes into the health education. So back to the bill, because I hear Ron in my head, even though he's not here right now, I hear him, but go ahead.
Can I just answer it? Because I have a few patients like that. I have an outpatient clinic, and I work in the hospital as well. And I have a few patients that, were your quote unquote frequent flyer patients, frequently coming into the hospital, frequent going to the emergency room, maybe just evaluating the emergency room, maybe stay a night or two, and then end up going home. And that's just healthcare money. The answer to that was simple. I just have them come to the office more often. And when they don't have to pay a copay, and when insurance is going to cover for it, guess what? Their overall healthcare expenditure is a lot less now. So I have a patient that used to go into the hospital at least once a month. It was almost clockwork. I see her in the clinic every month. She comes in, I see her, she comes out. I'm very sure she's costing us a lot less money now.
Yeah, I agree. I wish I'm gonna send you my patients. But no, like I said, the reason why I bring that up is because it's not just a conversation that's in Shaburt. It's actually coming from the other health professionals as well. And I just thought that it would be actually a good conversation, because we don't really go down this road too much. And it's going to be another opposition piece that they were like, well, look at all these high cost patients are going to cost. This is going to break the system. It's not sustainable. We won't be able to afford it over time. But like you said, this is where the implementation of CalCare is going to be important, because right now, the kind of the thought process of the average person is, I'm sick, I go to the doctor. When it should be like, well, you know what? I'm healthy. I still time for my annual physical. It's time for me to go see my doctor. And we need to also have a promotion of health in outside in our world of medicine, and outside we need to be working on health promotion and preventative care. That's one thing Kaiser does right, with the, they really heavy focus on preventative care, mainly not because they care about the community more so, but that's how they make their money. Anyway, sorry, I digress. So I just wanted to, really open that conversation up, because like I said, I don't think we've really gotten deep into it. And I know that that's going to be a continuous conversation. And I think that, people like us will have to be the face of that conversation, because they need to hear it from doctors. They need to hear it from nurses, that the key to cost savings is that not the fact that everyone's just going to run to the ER. Maybe some will, sure. But once we get them a doctor and get them established with that doctor, especially, and then them knowing that they're not married to that doctor. If that doctor's not working out for you, you can change doctors. Now, granted, there's some caveats to that too. But at the same time, I think that is what's going to keep people in the primary care world than the hospital world, where we see the highest utilization. Also, you mentioned end of life. I actually did a nice lengthy paper and presentation about the urge of palliative care. We are very much so in America. We are not a palliative end of life type of country. We are a prolonged life, live to my last breath. Like, I want to just keep living, even if I'm a vegetable type of country. And we need to also talk about that in health promotion too, and palliative and living with dignity, all that stuff, because these are where the dollars are going to be spent. If we have to change our current healthcare mentality to also save the system. So it's also on us to make sure that we stay healthy, our families stay healthy, and understand, because we also are responsible as the community, as the people, to sustaining this as much as the legislators are responsible for passing it. Okay, so now I'm going to go to James. You had your hand back up.
Yeah, what I tell people is that it's not like open bar for the next hour and as many drinks as you can have, because it doesn't work that way. And I also say, if you show up to a hospital and say, you know what, I watched last week's episode of Grey's Anatomy and The Good Doctor, and I think I've got 5 different ailments.
Hate those shows. Hate those shows.
And I want to be hospitalized for observation for the next 7 days. Now, if your physician doesn't see any medical need for your claims, they will say, just go home and rest. I've actually stressed that. People have said it's an on-demand medical service. It's not like picking what movie you want to watch. You go there, you get checked out, and if there's no basis for it, they will send you home. And they go, oh, really? And I was actually kind of surprised they didn't work that out for themselves.
No, so, I mean, well, it goes back to,
Can I just jump in on that a second and say, and people are okay with that when they don't have $100 copay. I mean, if they come in and they say, I'm not sure if this is chest pain or heartburn, and you say, oh, it's just heartburn. And then they get angry at me because, they have to pay $100 to be told they had heartburn. So, I mean, you're absolutely right, James. They should be encouraged to come in, get told they have heartburn, and then they can go home and, you know what? They feel better. They can concentrate on their work and their family. They're not, so that's a big part of the problem.
And I love that because you get peace of mind.
Can I also just add that not only can that happen, but then you would have access to having follow-up as well, right? I mean, the amount of times that an ER doc has called me up and said, hey, I got this guy, he's got this cough and I don't know what to do. And he does, and I'm not sure. And I'll tell him, well, why don't I see him in the clinic tomorrow? Why don't you send him home? Because he looks like he doesn't need to be hospitalized, right? And that then saves money, because otherwise the patient would be hospitalized. And so that's something that's going to be available to all of our patients, because we're going to have a greater amount of physicians at ready for them, right? Instead of being that, oh no, wait, he only has whatever insurance, so this physician can see him and only that physician. No, he can see any physician. So it makes a huge difference in terms of that follow-up care once you're being evaluated at either an urgent care or an emergency room, etc.
And trust me, we don't authorize if you get admitted to a physician that's not contracted. We will not author. So then that hospital has to spend more admin costs fighting our claims department, because why didn't we not authorize this admission? You brought up a good point, but that just healthcare bloat. Going back to the 7 basic principles of CalCare, we are eliminating healthcare bloat by getting rid of things like that. Me not authorizing because, well, it got Dr. Wynn's not our hospitalist who admitted to this doctor. Okay, we're not authorizing because it wasn't admitted. They weren't admitted to our hospitalist. And like I said, it just, now you've got hours of people fighting these claims. Okay, we're in the last 10 minutes. Erica, see, you got your hand up.
Yeah, so just so many wonderful things. Oops, I was trying to take my hand down. Earlier, when Dr. Wynn was talking about we should talk just not about just the uninsured, but the underinsured, I also just wanted to say, also what CalCare is giving, we're not giving people insurance, we're actually giving them health care. So we need to emphasize there is a difference in insurance and health care. I mean, your insurance is worthless if you don't get health care. So please just keep that in mind. This is health care. Also, you know, every time I hear the word access to health care, it's, you know, it strikes me as the Republican talking point. Like, I hate when, you know, I mean, we're not giving access to health care. Like you said, Jeanna, I have access to mansions. I don't live, you know what I mean? Like, it's not access. We're actually giving health care. So just wanted to point that out. And then I really appreciate the question that you asked, Jeanna, because I think what's so, even though I rolled my eyes, but what's important about your question is because you're in there and you're hearing it. So all these questions are really important and we all need help. And like, well, how do I answer this question? And it was so helpful for me to hear the doctors weigh in. So thank you so much, Jeanna, for asking that question. And you know, my eye roll wasn't to you, but
no, I know that question makes you like because I brought it up before and you're just like, but, and it's like, that's the rate, that's your button, your trigger. And I was like, but I wanted to ask that question for you and the people watching, because I'm hearing that from the inside, not just outside, the inside of the inside. Yeah.
And remember the end, like, to me, that is an opposition talking point. And it's filtered into it's not just, it's filtered everywhere. And also that talking point changes. Like, then once you answer that one, they'll be like, oh my God, everybody's going to move to California and our whole country is just going to break off the continent because there'll be so many people. Like, it just like keeps changing form. But anyway, I loved the doctor's answers. And also, yes, most of us, like, I do have whatever I can go. The amount I'm not, my checkups, I'm like, oh my God, okay, I've got to go to the dentist. Like, I don't live to go to the dentist and to go to get my checkups. Like, I'm grateful for it, but I don't want, I'm not going to go to the dentist more than I go, like, because we have CalCare. And when I hear about like these people, Jeanna, that you guys see in the emergency room that are the hypochondriacs or whatever, well, to me, you know, maybe there's mental health there. And with CalCare, they're going to get their mental health addressed because they're going to be seeing therapists and be like, okay, you're feeling the urge to go to the emergency room again. Okay, let's talk about that. And
we need a hotline for that. You feel like you need to go to the emergency room, call this hotline.
So it's like you've got like what the doctors pointed out, the medical aspect, but also we get mental health care. And a lot of that could be a mental health care issue, that these people are hypochondriacs, or I don't know, they're single and they want to see what handsome doctors on call at the emergency room. We
know what?
Talk about that too. Or what cute nurse. I don't, you know, but Anyway, it's just a
Yeah.
fun little answer to that. But I do want to say the last thing, and then I will be quiet. But when you guys were talking about the political leaders, I think we're naive. Okay, I'm willing to give some of them the benefit of the doubt that they don't know the total ins and outs of the bills, which is why I'm constantly inviting them to come to CalCare office hours, because this is an incredible resource that is available for anybody to come on and learn more. And so if at this, if they continue to not really know it, it's on them. There are lots of resources. The Cal nurses have resources to know it. But I think that they know it. I think it's about the money that they're taking. But I just want to say this. After the supermarket massacre in Boulder, Colorado, Chris Murphy made a statement from Connecticut, and he said, "I have just come to the conclusion that Congress has become complicit in these crimes. When Congress doesn't act, it sends an unintentional but very real sign of endorsement to these would-be killers. It looks like we're approving the way in which they are managing their grievances because we don't do anything year after year. I am at the place where I believe when you look at what Dr. Bill put in the chat about how many lives would have been saved if CalCare had been implemented, it is getting these members of Congress are complicit in these deaths. To me, it is getting to the point where it's almost like if a person was about to be killed in the street and I could stop it or I could walk away, most people would stop it. By the power of their pen, they could stop people about to lose their lives or lose their health, lose their limbs, or lose their savings. And they are complicit. So.
All right. Silence is, silence and inaction is the same as violence. So there you go. Those are some good, strong closing words. But I just wanted to also, I was looking up, James, you brought up a good question. What was the cost of unnecessary ER visits? And, I saw this article, they were saying, granted, it's from the Kaiser Health Family Foundation but it says that a trip to the emergency room on average is 12 times higher than that being, I'm sorry, I'm being rude. I shall share this. So here we are. Can you guys see? So yeah, there you go. This is I'm not too old. So pretty relevant, I think. But 12 times higher than being treated at a physician's office for common ailments. Of course, an analysis from the United Health Group. Oh, that's where my bonus went. Anyway, I say that to reinforce what Dr. Bill and Dr. Wynn were saying. We need to focus on preventative medicine. And that can happen when people are given CalCare and have ability to go see a doctor on a regular basis than just when they're sick. But also we need to be in the implementation, telling people you can go to the doctor, see your doctor for this. And so providing that access to that care is very important too. And then educating people like, George W. Bush saying, go to the ER, I will smack you. Don't you dare. And so 12 times higher than a physician. So CalCare is also a preventative medicine bill. So I can word it a million different times. CalCare let me rephrase that. CalCare is a preventative medicine bill because you are giving people access to preventative medicine. People who just utilize the emergency room a lot, yeah, there is a mental health factor to that for sure. We see it a lot. But there's also the factor that I don't have a doctor. How many times, Dr. Bill, Dr. Wynn, do you hear, I don't have a primary doctor? I mean, you know, we hear that all the time. I don't have a primary doctor. So that lets me know that that little sore on your foot that now has osteomyelitis and you've got to lose a toe probably could have been fixed if you just would have had a primary care doctor who would have given you a prescription for antibiotics and probably some insulin to fix your diabetes or to control your diabetes. But, you know, I think that I just wanted to share that because this is a really big number. And granted, I'm just going to also emphasize this is coming from the Kaiser Health Network, the Kaiser Family Foundation, from an analysis from the United Health Group. So they know that this is not the way to go. And they're saying right here, treated at physician's office for common ailments. So back to promoting preventative medicine bill. So there's another talking point right there. This is a preventative medicine bill. So, okay, I just, we're at 7 o'clock. So I just want to wrap it up. Anybody have any last thoughts, questions? You know, because I know for most of us, we have been on Zooms, like I said earlier, all weekend long, 4 or 5 hours at a time. This is not about to be one of those. I love you guys, and you know I love talking to you about this bill. But yeah, I was like, I just want a few hours of my weekend.
Thank you so much, Jeanna.
No problem. But anybody have anything?
This is therapy, right?
It is therapy. I love it.
Yeah. So it was wonderful. Thank you.
Maybe
Thank you,
everybody
Jeanna.
could bring a friend next time.
Yeah, each
Bring
one
it
teach
forward.
one. I want to end with that. Each one teach one. So anything you've learned, take it back to the community and, you know, bring somebody with you if they're interested. But, you know, definitely more talking points, more outreach. That's the only way. It's almost like the COVID vaccine, you know, being one of the first people to get the vaccine, you had to prove to people this was safe. And that's why I did it.
Jeanna, can I just add to what Erica was saying about access is not care? You know, the older movie, the healthcare movie that compares Canadian versus American healthcare. I think that's a really good movie that that talks about how it's care for the whole community. It's not, you know, access. It's not, you know, it's like it's part of the whole community. The theme is community. It's not, you know, access. Fix It Healthcare is like, how do we get access for people, right? But the healthcare movie is I think it's much more kind of like personal and human, and it talks about the end of life. It talks about, you know, childcare and kids with congenital birth problems and stuff. So to me, that's more like holistic and more about care, you know, not access. So that's a
Sounds
good
like
one.
we may
Yeah.
have a movie night coming up soon.
Movie night.
Yeah.
Oh, just really quickly to everybody out there on Facebook, mark your calendars, May 24th, 7:30 p.m., Facebook Live. We will have Dr. Paul Song talk about the public option. So you know who I want you to bring, Jeanna. So bring that person, bring their friends, bring everybody who is talking about the public option. May 24th, 7:30 p.m., Facebook Live. And finally, if you like what you heard today, put 5 on it by going to hcala.org, donate, and thank you so much, all.
Thank you guys for attending office hours. We will be back next weekend, same place, same time, maybe a different face. I don't know. You guys have a great weekend and take care.
Bye-bye.
Thank you.
Thank you.